Hello, everyone. Again, this is Karen Carlucci with the Lifeline. Thank you so much for joining. We have a good turnout already, and we will definitely be hearing several more beeps, I suspect. That's conference line will join or exit, and they should taper off. So thank you for being part of this webinar today, Crisis Center Sustainability. We're very happy to bring this to you today. This is first a part of a larger rollout that the Lifeline has been doing in introducing best practices throughout the year, which we started back in January. There has been a recent blog, just to bring your attention to that, which summarizes what we have brought to the network so far and touches on what we have to come in 2015. So stay tuned for information about that. So each month we aim to bring the network and our affiliates a webinar. And I'm very excited today to have 4 speakers joining us to talk about this topic related to Crisis Center sustainability. Again, please keep the phones muted and also remember to not place this conference line on hold. We will do questions and answers at the end, as well as comments. Let me first go over what we will be covering today. We will then hear just a brief message from John Draper. He's joining us for the beginning portion of today's webinar to say a few words, and then I will introduce our speakers. Okay, so we will be reviewing the following: the Crisis Center Sustainability Toolkit, its components and purpose, how to apply certain aspects of this toolkit at a crisis center. We will review some return on investment information and strategies, as well as some grant information that might be useful to all of you. And then a little bit on crisis center return on investment efforts that have been happening. John, why don't you tell us what you would like to share today while we have you on the line?
Thanks, Karen, and thanks to all of you for joining us today, and as well as our presenter for providing their time to convey some very important information to all of you. Speaking of time, it has been quite some time since we began putting this thing together. The Sustainability Toolkit, you may recall, was first being discussed back in 2011. And it's been in development and through SAMHSA clearance processes ever since, and finally, today we have it. The timing could never be better. I mean, it's always a good time to have a sustainability toolkit, but in this case, there's a lot of attention, as you all know, being paid to suicide prevention right now, not only because of Suicide Prevention Month coming up, and that's certainly an opportunity, but obviously with the recent tragedy related to Robin Williams' suicide and all the attention given to suicide prevention around that, does create an awareness of the importance of all of our services. As you know, calls really increased. Not only do you know, you're all the ones who are receiving those calls, more than double the typical number of calls on the day after he killed himself. And now, today, it's about 1,000 calls still above the previous baseline before the media started reporting his suicide and giving out the number. So what all that means is that the nation and your local communities are thankful to have a service such as this, such as yours, to be able to respond in times like this. But a lot of them don't know that it costs money. And it's important that they know that as lucky as they feel that you're there with them and for them, they also have to be with there and for you. And that's the communication to all of our stakeholders. So take this sustainability toolkit and we'll help you in any way we can to make that argument to your stakeholders, to give you the resources and support you need to give support to your community. So thanks to all of you, and I'm going to have to get on a task force call in just a moment. But I'll tune in for the next half an hour or so, and I'm looking forward to hearing what's being said. Y'all take care.
Thank you so much, John, for taking that introduction. Okay, well, let's get rolling. We have a lot to cover. Our presenters today, we will first hear from Mary Yukaitis and then Michael Labonte from one of our centers. James Wright is joining us from SAMHSA, and finally David Westbrook from another one of our Lifeline centers. I will more thoroughly introduce each speaker right before their portion. And at this time, we are going to get started and hear from Mary Yukaitis. A little bit about Mary's background. Throughout her long career, Mary helped plan and implement major prevention programs and campaigns related to suicide, alcohol, and drug abuse, as well as mental illness and many chronic diseases. Mary currently helps and develops national programs that use social marketing strategies to increase public awareness, change attitudes and behaviors, and improve professional practices. She currently serves as a partner at Trillium, a woman-owned firm specializing in strategic use of communication and marketing for preventing illness, promoting health, and creating positive change. At Trillium, she supported a Gallup contract with SAMHSA to help communities effectively use communication strategies in youth violence and suicide prevention efforts. In this role, she created key pieces of a kit to help Lifeline Crisis Centers enhance sustainability and served on a team that prepared media guidelines for bullying prevention. Mary holds a Bachelor of Arts in English Literature from Miami University of Ohio and a Master's in Health Communication from the University of Maryland. Mary, you there?
Sorry, my phone was muted.
Oh, that's what happens. Go right ahead.
I'm so sorry. Karen, thank you so much for the nice introduction. And I'd just like to begin by saying that I'm extremely pleased to be here and talk with you today about the Lifeline Crisis Center Sustainability Toolkit. A bit of a mouthful there, because I was privileged to work as a member of the team that developed the kit, as Karen told you. I speak for others on the team today to really excite you about this resource and encourage you to use it. As John told you, the kit was a long time in development and clearance, and now it's finally available in your network resource center. The development team is really proud of the final product. But we want to acknowledge that many of you also played important roles in its success by telling us what you need and contributing great suggestions in the process. And I'd also like to acknowledge all the suicide prevention leaders, such as John Draper, and the SAMHSA staff who were so helpful in supporting the development process. And just on a personal note, I'd like to say to everyone that the work on this kit provided me such a deep appreciation for the value of the center's work. And I'd like to thank each of you for your work and commitment to helping people in crisis. Going on to the objectives for today, I'd like to first take a few minutes to give you an overview of all the work that went into it, just to give you a sense of how much effort went into making it a helpful piece. Then we'll walk through what you can find in the kit, pointing out how to use each piece. And finally, I'd like to review some of the key steps that you may want to plan and carry out a marketing effort using the contents of the kit. We aren't going to dive deeply into marketing methods, but we'll look at a few basic steps that will help you get going in the right direction. Before continuing, though, I'd like to just digress a moment and tell you a little story about a presentation I made to the Lifeline Steering Committee. And when I finished, one of the center directors asked me a really tough question about how we think we could use a marketing campaign to realistically help crisis centers during an economic downturn when everybody's budgets were being cut. To be honest, I didn't come up with a good answer to her at the time. But after we began developing the kit, the answer became very clear. There's a powerful, untold story about how effective centers are in saving lives and avoiding the high economic cost of suicide. Getting that story out clearly is an essential survival strategy. We hope this kit will allow you to get these important messages out to the community so that others can be helpful in supporting your efforts as well. Could you have the next slide, please? Here's a little history, overview of the history of the kit. It summarizes the major effort that went into making it both accurate in presenting research-based data, but also really helpful and practical for everyday use in your programs. The development team knew that to be credible, you needed sound evidence from scientific studies. Otherwise, you wouldn't be able to convince people that suicide has prevention has an economic value, as well as its important humanitarian goal. But we also knew that unless we could package it for easy use, it really wouldn't be helpful to you. So we began a two-phase development process, as you see sketched out on the slide here. First, we really did a huge search for sound evidence about the effectiveness and value of the centers. And then we worked extensively with center directors and others to package the findings in a way that you told us would be helpful. Some of the things we did in that process, and you see some of the collaboration, pieces of collaboration I mentioned on the slide, but we interviewed a wide range of experts. We convened an expert panel. We attended Lifeline committee meetings and conferences, and in those settings we discussed key issues and got your feedback in developing draft products. The result is that we think will meet your needs. You and your colleagues have played such a major role in helping us create it. And can we have the next slide, please? Here you see the purpose of the kit, and again, these are things we heard directly from you. You asked us to help you present evidence for the value of crisis center work, and to help crisis centers conduct effective outreach and promotion. And there are many requests for top quality materials that you could use without spending lots of time and money developing your own. If we could go on to the next slide. This is just a title slide for part of the presentation where we're going to call our attention to the contents of the kit. And as I go through this presentation, I'm going to be using the word marketing. I know sometimes we're kind of cautious about using that term because we're not used to it, but your centers are going to have to kind of do the same activities that you would if you were a retail outlet in this tough economic time. This next slide presents a list of the pieces that are in the kit. Some of you already may be familiar with it, but let me just quickly mention it includes a guide. It includes two pieces that provide the kind of scientific evidence that you ask for. That's the white paper and its executive summary. Then there are two customizable materials for wide-scale distribution. One of those is a fact sheet, and the other is an issue brief for policymakers. Then you'll find a group of materials that will help you develop your own messages and presentations using templates so that you don't have to do all the tough thinking about how to do it. We have a video PSA that was a much asked for piece, and it's available in 3 different links for your use. I think you can see from this a comprehensive marketing campaign and one easy to use, what we hope will be an easy to use package. Starting with the user's guide, I won't go into a lot of details here. You see a little thumbnail sketch or a photo of the first page of it. It just introduces what's in it and explains how to use it and gives you a little snapshot of how everything fits together. Going on to the paper, we've got a photo of the executive summary on the slide here, and you can see some of the key points about the white paper. But I'd like to just tell you a little bit more about that. The full-length paper is a type presentation, and it's written in a style that's suitable for lay readers. But its purpose is to introduce the work of the Lifeline Crisis Centers, along with statistics about the scope of the suicide problem and its cost to society. It summarizes research conducted by Dr. Madeline Gould and her colleagues at Columbia University. And a concluding section presents results of a study examined the return on investment generated by a suicide prevention hotline. This paper presents convincing evidence that what you're doing has enormous value to the community. Reading it will be an essential part of preparing yourself and your staff to market the center more effectively. And it also provides great copy for writing background sections of proposals. It's not copied so you can feel free to use it as it is. Just cut and paste it into your document. The full white paper isn't intended for widespread distribution, but it can be a valuable tool to give potential donors or policymakers who want in-depth information. And the executive summary is designed for possible use with wider audiences. Going on to the next slide, you'll see a copy of the fact sheet template. From paper in different ways to meet a variety of different marketing needs. These pieces are what we call Swiss cheese materials. They have blanks where you'll need to insert your center's name and address or other information to describe the suicide problem in your community. Because as we all know, you really need to customize and localize your marketing materials and to make them resonate with your audiences. Once you fill in the blanks, which isn't a really difficult task in most cases, you can just print them out and you'll end up with very polished, professional-looking materials that you can put to work for you. The fact sheet template was designed to be a multi-purpose piece that you can use anytime you want to share information about your work. It stresses key points for 3 basic themes of the white paper in the kit: saving lives, saving money, and serving our community. This piece can be a workhorse in your center's marketing efforts. Just fill in the blanks and print out lots of copies. Going on to the next slide, you'll see a brief snapshot of the issue brief, which, as I mentioned, is for use in talking to policymakers, and that would include people like your state legislators. It could be governors, mayors. It could be the head of the state public health and mental health services, people like that. We all recognize that the path to sustainability requires reaching out to people like this. And this 2-page summary is geared to the interests of these people because they're in a position to make laws and policies to help you, and they control allocation of funds. The piece, as we developed it, it was designed to help you make a convincing business case for the work you do. It's often the hardest point to make for crisis center spokespersons because we often have difficulty thinking about financial issues when lives are at stake. But policymakers have to think about such issues, and they need help in understanding why crisis centers save money. We suggest using this product to guide your talking points in speaking to policymakers, and also as a leave-behind for them to refer to or distribute to their colleagues. You also might want to consider having a copy of the white paper to give them in case they want even more detailed information. Going on to the next piece, you'll see a photo of the talking points template. It presents suggestions, suggested points to make anytime you have an opportunity to do outreach for your center or talk to responders. It contains a tip sheet that tells you where to easily locate your state suicide data and insert it into blanks in this template. It also provides other suggestions for tailoring information to your needs. Karen, I'm going to pause here just a moment and let you know that I'm having a little problem. It seems like I have been disconnected from the slide set.
Okay. You
Changes in the slides.
okay.
So going on now to the PowerPoint presentation. You'll see here that it's the first slide in a tool for helping you make presentations to the public. This piece of the kit contains PowerPoint slides that you can customize to make different kinds of speeches or other presentations. It contains 22 slides, themes and points prominent in other materials of the kit. Each slide accompanying narration or script for you to use and tips for adding local related information. The prepackaged slide set permits you to get the messages across in a polished style with nice graphics and compelling calls to action. It offers you an effective presentation that will require very little time and effort on your part. No more developing PowerPoint slides and writing talking points. All you have to do is fill in a few facts about your center and you're ready to go. All right. Going on to the elevator speech template. I think he asked you to think for a moment how often you find to quickly explain to people what your center does and why it's important. And we designed the elevator speech template shown here to help you do that effectively. I think it's common knowledge that the average person's attention span is about 30 seconds. So you need to be able to make your pitch in the time it takes you to get from the ground floor to an upper floor when riding on an elevator. And that's how we use that as the theme for naming this template. Through the process of preparing a pitch in your own words for use during brief encounters or introductions that you have to make on things like webinars or at dinners or in other public forums. This is a do-it-yourself instruction that helps you make a big impression in a short time. It gives examples that help you decide what you most want to say in a memorable soundbite. It's obviously for use only by center staff and not for distribution to your audiences. Finally, I want to mention the video PSA that we developed for the kit. As you see on the slide here, it was the most requested piece of the kit. When talking to directors and staff during our market research, we heard over and over that everybody wanted a polished, short video that would tell the crisis center story in a compelling way. We're not going to take time to view the video today, and I hope that you'll, if you haven't seen it already, will do so. It's a very nice piece. But this slide shows some key points to remember when you take a look at it. Now, just a few words about why and how to use it. What we learned was that few local organizations such as crisis centers have enough marketing dollars to develop video products really appropriate for mass media use. And SAMHSA heard these requests and authorized us to develop a video in 3 different lengths, including 30, 60, and 90 seconds. They're all suitable for use by television stations and great to use on social in the PowerPoint slide template that we just viewed a few minutes ago. Some centers also mentioned to us when we were developing it that it might be helpful in training and motivating staff. We feel like the video can add tremendously to your outreach and promotional efforts. You can send copies to TV stations for use as public service advertisement and use the materials throughout your own presentations and online presence. And this slide concludes our brief review of the kit contents. And if Karen, you can advance to the next title slide, we're going to just take a few minutes and look at how to construct a strategic approach to marketing your center using these materials. The next slide, here's where you come in. Just acknowledges that in this part of the presentation, we're going to focus on how you can use the materials as part of a strategic approach to marketing. As shown on the slide, we'll discuss a SWOT analysis to help you plan your approach. Then we're going to consider how to select the audiences you will focus on. And finally, we'll briefly talk about how to persuade people to support your efforts. Going on to the next slide, this is just kind of a tip about, a practical tip about where you may want to begin. Before planning a marketing or promotional effort, it really pays to take a little time to analyze your current situation. This slide shows a practical and not very complicated way to do it. As many of you already probably know, SWOT stands for Strengths, Weaknesses, program, and just discuss the questions on the slide. We recommend writing the answers that you come up with on a flip chart, and then have a discussion about what the answers mean for a new marketing initiative. This next slide, called SWOT Insights, suggests that discussions that take place when conducting a SWOT analysis will provide many insights that can inform your strategic directions. Looking at strengths enables you to know what you have to offer supporters. For example, your audiences may not know that to become a Lifeline member, your center has to meet very rigorous standards of quality. Examining weaknesses is equally important because it tells you the barriers you have to overcome. Example might be state budgets for mental health services are never adequate, or that some decision makers may not view crisis centers as essential parts of a mental health service system. Looking at opportunities suggests that you position your center positively to overcome these weaknesses. One example might be increasing public awareness and concern being generated by the press. In fact, John mentioned that earlier. Another is availability of research-based evidence showing that hotlines save taxpayers money. And finally, threats suggest what factors you may have to overcome. One example is we heard from many crisis directors that sometimes you encounter an opinion that this kind of work is best done by volunteers instead of looking at it as more of a professional and highly trained and critical operation. Now, let's see now if we could go on to the next slide. Who are your audiences? After you have gained a bit deeper understanding of your situation from a SWOT analysis, we suggest that your next step will be figuring out which audiences are key to achieving your objectives. And we have a list up here. It's a short one. It could be a lot longer, but it just lists a few of the people, such as policymakers, foundations, businesses, and we sometimes say it doesn't reach anyone in ways that really resonate with them. This means that you need to select one or two primary target audiences to begin with and really focus on them. On the next slide, how to segment. This just brings up the emphasis that even after selecting a target audiences, you need to think about which parts of the audience will be most important to reach in order to get the biggest bang for the buck, given your center's situation. think about which professionals might be most important and then break down this large group into segments that are most valuable in supporting the center. Would they include primary care providers, mental health services providers, or maybe social workers? If you decide you need to reach policymakers who can change laws or direct funds to the center, where do you start? State legislators, county council members, the governor, his or her staff, or maybe your mayor? And then how about the general public? Would you want to reach those who could be donors or people in need of suicide prevention, family members, and so on? Or maybe you want to place your emphasis on members of the faith community or public opinion leaders. There are a dizzying variety of possible audience segments, but the important thing to do is identify a few groups that you can realistically reach given your resources. Then you need, if we could go on to the next slide, the next thing you do is to really need to think about who are your audiences or audience segments. Think about what they value or believe, whom or which sources of information they trust, where they can be reached, and my favorite question, what's keeping them awake at night? Think about, can you solve a problem for them? And also considering, are you sure about your conclusions, or are you making assumptions? Before concluding these activities, it's usually wise to get a small group who can assist you, write the answers down, and discuss the insights they offer. It's also often really essential to talk to the members of the target audience for additional guidance. Finally, you need to figure out your approach. As shown on the slide, you'll need to think specifically about what you'll do in order to reach your audiences. Some key issues to think about are, how will you reach them? Would it be by TV or newspaper, social media, or meetings, or community outreach? Think about what materials in the kit would be most useful. Who will be your messengers? And what time frame will be required to make an impact? Moving on to the next slide, called From Informing to Engaging. I just want to switch the focus a little bit from how to plan and carry out strategies that educate people to some ways that you can get them to take action that support the center. As we all know, just getting out messages probably is just the first step in a long process. The kit provides great materials to use in educating people about why they might support us. But as this slide shows, you need to do more than just use good materials to move people from awareness to commitment. As the graphic suggests, you must begin by informing your audiences using the materials in the kit, but then you have to employ strategies that will actively engage them. And, social media is extremely helpful in doing just that. But it's also an opportunity to use the great people skills that each of you use every day in your work with the center. As the slide suggests, some great approaches include asking questions, dialoguing with audience members, listening to them, and making direct requests for support. Social media makes this job a lot easier to reach and interact, but you have to get out there and work with people as well. Going on to the next slide, showing the picture of two hands and some questions. This slide's intended to illustrate another important thing about engaging people. It reminds us the fundamental principle that underlies all persuasive communications. This is an illustration of what's called the exchange theory that explains how people evaluate every system from the point of view of what's in it for me. So if we stop a minute and think of what this theory means for the job of getting support for your center, it suggests that while your audiences aren't likely to understand that suicide, are likely to understand generally that suicide to expand awareness of the suicide problem, with a clear statement of why each community member has a vested interest in their local crisis center. Now I'd like to go on to the slide called Generating an Ask. That just reminds us that using the exchange theory as a guide, you need to be really direct in how you ask people for what you want. As shown here, you need to define what we call a hard ask, which we're going to talk about talk a little bit more about in just a minute. But some examples of things you might want to include in your ask, or if you're talking to the general public, you could ask for volunteers. You could ask for donations, for money. But with other groups, for example, policymakers, you could help them make suggestions for new laws or regulations that would help your crisis. And one other thing we learned from our research is that a lot of centers are using their backup capacity to help businesses answer telephones, supporting physician practices or employee assistance services. That's another way to generate some additional income for your centers. I've used the word hard ask in just talking about the slide just before this one. And I want to just here in this slide called soft ask versus hard, just kind of illustrate the differences. I think we're all comfortable with saying things like, we need your support, or a donation would help us meet our needs. To create an online crisis center chat service. Or your donation of $10,000 would allow us to start something. That approach is likely to elicit more direct response from people. And then this last slide called Closing the Ask just reminds you that just like the car salesman, you've got to get them from wanting to help you to actually doing it. And here again, the exchange theory suggests that when you close a request, see on this slide, you see several examples that you could solve a problem for the community, or you could position your organization as a community leader that way. And in closing, I'd like to just leave you with a couple of calls to action. I'm hoping if you haven't done so, you'll review the kit. And I, again, hope that maybe that you'll be able to put some of the marketing tips we just discovered to work. And finally, with the hope of the kit, I hope you'll get out into the community and achieve great success in your marketing efforts. But just one final word too. When you do go out into, if you were to actually try to go out into your community to find a communication relations firm, meet demands for services, it'd take lots of your time. And it's not likely that you could find a firm that really knows the nuances involved in suicide prevention. SAMHSA created this kit to enable centers to carry out effective marketing without all that trouble and investment. Please do take advantage of the investments made in developing it, and best of luck in using the kit. And I think it's the all of you, and good luck with your marketing efforts.
Thank you so much, Mary, for that thorough review. It was really important to go through all of those layers of the toolkit. Right now, yes, seeing just a snapshot of Crisis Center Sustainability page can be found on the Lifeline Network Resource Center, networkcenter.org. Just go under funding. and then you will see this page which outlines some information related, of course, to sustainability and has links to each piece of the toolkit, including the public service announcement video versions toward the bottom. So thank you for that. And just to give you Mary's email in case some of you have specific follow-up questions, whether it's about the toolkit development and its use or something separate that you'd like to communicate to Mary, you can we can have other questions taken at the end, but feel free to continue chatting in and we'll get to what we can during this webinar as well. So now we are going to hear from Michael Labonte, Executive Director at the Memphis Crisis Center in Tennessee, one of our network centers. Mike Labonte has an MA degree in urban anthropology from the University of Memphis and is the Executive Director, as I mentioned, at Memphis Crisis Center, a partner with the University of Tennessee Health Science Center. Workers, 911 dispatchers, counselors, and community volunteers in empathic listening, risk assessment, and crisis and suicide intervention. He is a certified trainer in multiple intervention curricula. He is the former chair of the Memphis Shelby County Suicide Prevention Network and serves on the boards of the Memphis Mental Health Institute, National Alliance for Mental Illness, the Memphis chapter, and is governor appointee to the Suicide Prevention Advisory Council of the Tennessee Suicide Prevention Network. So he's involved in a lot of things as well. And let's move on to hearing from Mike.
Karen, thank you so much for asking me to come and present. I just want to say this has actually been incredibly helpful to our center. We have been through a period of real capacity building. At the time we were under a larger agency and we became independent, and really using a beta version of this, we were able to really generate not only greater capacity but also sustainability issues. One of the things I loved about the toolkit is its customization and flexibility. One of the things that I loved about the kit, and that was something that came in, was so much of the language that's being used. You know, they were talking about cutting and pasting and that sort of thing. A lot of that language is so adaptable, but it's also so solid that it gave me a point from which I could actually talk to the and evidence-based issues. Use that important language that's in there, including I had not myself really considered. You know, when I was using pieces of this kit, it was even after we had some of those first major public shooting incidents, and talking about the benefits that crisis lines have in terms of de-escalating people, not having to send necessarily emergency help, which can be very costly, escalating people on the line, also connecting people into other sorts of really cost-saving issues, including people not tying up 911 lines. And we all know that with our population of regular callers, our mental health consumers who were part of their support system, that piece plays into it as well. So the customizability, the flexibility, the language that's actually there in the system, in the kit, that I was able to just utilize directly, it really gave me a lot of confidence when I went and approached groups. I did not have access at that time to the the elevator speech, but I used a lot of the language from this kit to create my own elevator speech, which has been very successful for us. The other piece is the way it brings together so much of the evidence that, as was pointed out, if we all had to sit there and kind of do our own research, would take us a while. It just pulls it all together in such a way that, and also the information on where to get our own state stats. I've used it in a number of different ways, and if you want, you can go ahead and go to the next slide. One of the things that I did is I used a lot of the language in our annual report to donors. I basically created a fact sheet that kind of pulled together, and it had like subtitles like health, life, community, but it also had things directly from the kit, like needed now more than ever and cost effective, things that would talk to sort of not only what we were going through in terms of the economic crisis, but the bottom line. $100,000, and obviously the kit played a role in that. Again, we were in a capacity building phase at this point, having sort of become newly independent. And so we went to places like the Assisi Foundation, the Community Foundation of Greater Memphis, and the Plow Foundation, and so much of the language, but also that evidence-based piece was so critical. The other thing is United Way at one point had pulled our funding. We ended up getting that funding back, but one of the things that I noticed was there wasn't a lot of evidence-based information in terms of impact that was in some of the United Way reporting that we had done in the past. This kit allowed me to really make this very strong to United Way. In fact, not only did our funding increase after that, but the interesting thing was, after doing the presentation to United Way, I kind of joked with them about, what do you think of our funding options here? And the person who was one of the volunteers from United Way said to me, looked at me, and he just smiled. He said, "You guys save lives." So it really allowed me to make a very powerful pitch in terms of what our agency could do. The other piece is just media interviews. I have to say, so much of this information I have recycled and used and repurposed for media interviews. And to me, what I like about the kit, and I'm just going to put it out there, it's a one-stop shop, essentially. You go to that kit, and there's some that I have not used that I'm very excited about using, such as the slide piece, because the pieces that I had used have been so successful for us. I don't think that we would have been as successful in terms of our foundation grants and getting our United Way funding increased without having had access to some of this information. So I just want to thank the Lifeline for making this available to folks, because I really think this is going to be a tool that this is not something that's going to be sitting if we use it. Thank you.
Thank you so much, Mike, for taking the time to explain how you have implemented these certain pieces. I think it's extremely valuable and really appreciated by your peer centers to get some of those ideas. And it's possible that some folks might wish to reach out to you to discuss that a little bit further and see if you have any other helpful hints. So we have Mike's email address right here, where you can reach him at the Memphis Crisis Center. And you can also, of course, take this opportunity while we're still on the webinar to chat in some questions, and we'll do our best to get to some of those, or your comments too. Feel free to share any thoughts along the way. So thank you again to Mike Labonte. We are going to now to the return on investment portion of this presentation, and this is where we are very lucky to hear from James Wright from SAMHSA. And there we go with his introductory slide, and I'll tell you a little bit about James. James Wright is a public health advisor in the Suicide Prevention Branch, Center for Mental Health Services at the Substance Abuse and Mental Health Services Administration. Mr. Wright serves as Government Project Officer for the National Suicide Lifeline, Crisis Center follow-up grants, and represents SAMHSA on the Juvenile Justice Task Force, National Action Alliance for Suicide Prevention. He is also the lead GPO, Government Project Officer, receiving Garrett Lee Smith funds to provide suicide awareness and outreach across the United States. Mr. Wright serves on the editorial board for StopBullying.gov and the Federal Partners on Bullying Prevention, serves as the Center for Mental Health Services representative for the Health Information Technology Team and the Federal Interagency Committee on Traumatic Brain Injury. Mr. Wright is a licensed clinical professional counselor, previously managed a psychiatric emergency department for both Johns Hopkins Bayview Medical Center and Austin Travis County Integral Care. Mr. Wright is also a veteran of the United States Army. So we're very happy to have James Wright here with us today. Welcome, James.
Perfect. Thanks, Karen. And we can go ahead and go on to the next slide. On behalf of SAMHSA, I really want to thank all of the centers for your work responding to those in need, specifically in these recent weeks where there has never been more of a demand for the life-saving services that you offer. SAMHSA has placed a high priority on identifying and responding to those in crisis and following those individuals after receiving emergency care. So through the Crisis Center follow-up grant programs to the work on the emergency department integration, we have recognized the need for enhanced partnerships with medical providers to help reduce the risk of suicidal behaviors in the days and weeks after a crisis. So work that you have done has shown that this has been effective. And now we are focusing on showing that it is not only effective in saving lives, but in saving resources. The return on investment model I'll be talking about today builds off of the previous work that we have done with Truven Analytics. If you can take a look at the 2012 and 13 publications, and I've highlighted them on this slide, the return on investment from better care transitions and the hospital readmissions among Medicaid patients with behavioral health disorders. If you can, both of these really gave us a platform for working on this new release of the post-discharge follow-up calls for suicidal ideation or deliberate self-harm. This builds off of the findings and the models that were put forth in these two previous publications. So next slide. So the framework I'm going to talk about today really focused on individuals who had had suicidal behavior who were discharged from the hospital or the emergency department. These individuals would in theory, these individuals would immediately receive a post-discharge follow-up call, and some would be followed up at different increments. The goal was that there would be an increase of those who received follow-up treatment within 7 days of discharge, and then there would be a decrease of those in the 30-day hospital readmission rates. And this is important as we look at Medicaid moving forward, that actually penalizes some diagnoses for recidivism back into the emergency department. So next slide. So the components of the return on investment, what we tried to do was look at what is the actual cost of follow-up calls, what is the cost of this increase in follow-up treatment, and then what are the savings from the intervention. So we used a few things. We used a database from Truven Health Analytics, 2006 to 2000, and commercial claims, and then also their multi-state Medicaid database. We compared that to those reported from crisis centers through an 8-center survey. What we used for this was the cost per center. Roughly 75% of the cost of centers came from employee costs, and the other 25% were fixed costs. Next slide. So the ROI estimated for the 30 days after discharge that was calculated from a payer's perspective. So what this means is how much Medicaid or a third-party insurance company would save. So under the base case assumptions, it turned out that the return on investment was $1.76 for who were discharged, $2.05 Medicaid. And this is important because it takes an assumption of every dollar invested. So the return on investment would be greater than $1 for both payers across both discharge setting, as long as the post-discharge contact could be reduced by at least 13%. And the goal is that obviously the higher the higher the rate from the readmissions, the lower the cost would be. So if you could increase that rate higher than 30%, you would actually lower the cost for the insurance companies, thus having them save more money. So again, the break-even mark was $1 invested from the payer's perspective. Next slide. So what we wanted to see was how probable is this? So we did a sensitivity analysis and indicated that there was a 77% probability that we would hit that mark, that we would hit the 13.3% mark, with commercial and 88% amongst Medicaid, and that's from a hospital discharge, and slightly lower from an emergency department discharge, because those, it makes sense, those that would have to be admitted actually into the hospital setting, many of which thus go through the emergency department first. So what we found was that this study did support the business case for payers, at least, particular Medicaid, to invest in post-discharge follow-up calls, thus partnering directly with crisis centers. So with this, if you do not have access to the ROI paper, we will make sure that it is added to the resource center for everyone to review, including those other two publications that I mentioned. Okay, next slide. So what do we need? So again, all of these are hypothetical at the point. We're going to hear here in a light, but we need to see feedback from centers. We need to see, does this work? What is the rate of readmission for those that are going back into the hospital or into the emergency department that are in crisis, that are showing some sign of suicidal behavior? We also need to test. We need, does the model work, and then what is to the community and the emergency department crisis center collaboration? So is there an increase in utilization of your services? Is there an increase in health services overall community, and does the rate change? What is the actual rate? So those are the next steps for us to evaluate who in the Lifeline would like to take this model to the next step to see if it's actually going to be usable and if it actually works. Okay, next slide. Okay, so I kind of want to transition a little bit into a recent development on the Excellence in Mental Health Act. I want to make sure, number one, everyone's aware of it. This is part of a larger bill that got passed called Protecting Access to Medicare Act 4302. This act demonstrates one, if not the, most aggressive federal push for increasing access to care for those in mental health crisis. The act actually creates certified community behavioral health care centers. What this means is an entity is going to be designed to serve individuals with mental illness and substance abuse disorders and provide intensive, person-centered, multidisciplinary, evidence-based screening, assessment, diagnostics, and a whole host of other things. We're going to provide $25 million for states as planning to apply for the participation pilot. Then we will select 8 states to participate in this 2-year pilot program. Participating states will receive a 90% FMAP for all required services provided by the Certified Community Behavioral Health Centers. This means that's the federal matching program through Medicaid. This means that for every $10 a state spends, $9 will be reimbursed by the federal government. Next slide, please. So the Act starts with defining essential behavioral health services for certified clinics. And I just wanted to highlight a few of these. I'm going to tell you where you can get this information too. Under availability and access of services, The key component is including crisis management services are available and accessible 24 hours a day. Now, there's a wider range of services under it again, but this means you. You're all participating and all need to do what you can to make sure that your services are known and tied to this initiative because you are providing these 24-hour crisis management services currently. Also, under the provision of this act, it highlights direct crisis mental health services, including 24-hour mobile crisis teams, emergency crisis intervention, crisis stabilization, screening, assessment, diagnoses, including risk assessment, patient-centered treatment plan, outpatient mental health and substance abuse services, which include follow-up, and peer support and counselor services and family supports. So many of the things that I had talked about today, again, you are already providing. So I encourage everyone to take a look at the fact sheet from the National Council on Behavioral Health, the one that they put out online, and I put a link to it on this slide. The fact sheet includes a timeline for this entire process. Now, while the Act does not specifically address suicidal behavior, again, it does recognize crisis response as a core criteria of the scope of services to 24-hour MCOT services, emergency crisis intervention and evaluation, assessment, and stabilization. SAMHSA will be hosting an open forum requesting public feedback on these demonstration grants. When we identify when this will occur, I will make sure Lifeline centers are aware, and personally I encourage each of you to participate. This is where we identify needs from the community and must respond to those needs directly. You can participate remotely or in person. The evaluation of the Excellence in Mental Health Act should, by the end of calendar year 2021, give enough information about the effectiveness of the initiative to report back to Congress whether or not the program should be continued, expanded, modified, or eliminated. So this means that this act could be a potential permanent investment of the federal government. So with that, again, I want to thank you for all the work you do, and if you are willing to work on piloting the ROI model or have any other questions, please reach out to me or Lifeline staff. And next slide. This includes my contact information. So thank you so much, and if there's anything needed from me, let me know.
Thank you so much, James. That's really appreciated. A lot of important information that was just shared there. So again, you've got James's information up here on this contact slide, and you can reach out to him, or again, anyone over here at the Lifeline. We can help support you and direct you. Very good. So we are now going to transition to our final speaker, who is going to tell us a little bit about applying these return on investment efforts and what they happen to look like for this center, and that is Lines for Life. David Westbrook. I just want to share, by the way, that he happens to be on vacation. I don't know where he is. I hope it's somewhere lovely and that he's been relaxing up until this point, but he still agreed to participate today. So I just really appreciate him for making himself available while he's on vacation. And again, I appreciate everyone being here today. David Westbrook is currently the Chief Operating Officer at Lines for Life, based in Portland, Oregon. David previously served as the Crisis Lines Director at Oregon Partnership, which of course now is named Lines for Life. He was instrumental in starting Oregon's first and only statewide suicide prevention line, and was one of the original steering committee members for the National Suicide Prevention Lifeline. So we welcome David.
Thank you. And we can go to the first slide. Jump right in. So I'm really excited about the SAMHSA initiative. One of the things that I'm a strong believer in is earned revenue, or earned income. And that's revenue that nonprofits gain from goods and services, and it can take any number of forms. But what the SAMHSA work around the return on investment will force or help many of the crisis centers, our crisis centers do, is to think about things other than grants and donations. And it's really, the belief of many that in 10 years from now, nonprofits that are just trying to exist on grants and donations will either shrink or many of them will disappear. And that's where this earned revenue comes in. But it doesn't come natural to a lot of us who have spent our entire lives or most of our lives in nonprofits. So just quickly, a little bit about nonprofits earning revenue. Who does it? Goodwill, if you think about them, through the sale of goods. 62% of hospitals are nonprofits. Habitat for Humanity, resale of homes existing largely on volunteer work to create those homes. NPR gets about 55% of its revenue from sales of programs and other goods. And of course, the Girl Scouts, which we are all familiar with. So what is the, you can go to the next slide, value of a cookie? The Girl Scouts generate more than $700 million each about earned revenue to stay consistent with the nonprofit's mission. And for the Girl Scouts, part of their mission is helping girls to lead productive lives, and they see this as part of that mission. So just interesting to think about that. So let's go to the next slide. And either you're there and okay, I wasn't sure if my screen got out or.
This happens once in a while.
No problem. Okay, so the slide Karen has up for us right now is a little bit about some of the earned income that Lines for Life gains. And I'll say briefly that what is not on here that we also do is trainings in applied suicide intervention skills training, mental health first aid, assist, safe talk, and those types of trainings. So our earned income primarily comes from contracts that we have with a couple of different types of organizations. County crisis lines, which in Oregon answer their calls, or most of them answer their calls during the daylight hours, need or want a center to be able to take on those calls after hours. And this fits very nicely with our mission. And we do we charge them a flat rate and then a per call basis after they exceed a certain number of calls in a given period of time. Our smallest contract is about $8,500, and our largest contract this year will show revenues of somewhere in the $55,000 to $60,000 range. We were also fortunate enough to participate in the SAMHSA follow-up grant, and out of that, one of the things that came from that for us was contracting with an area hospital here, a private psychiatric hospital, to do follow-ups, which frankly we wouldn't have probably thought of this in the same way if we hadn't participated in that grant and in that effort. We were always doing follow-ups with folks, but we weren't thinking about it in terms of a return on investment, and that just launched us into a whole different way of doing it. So the follow-up calls that we take, or that we do, we become almost case management in some of these calls. But we do 3 calls. And I'm just realizing that I don't have a slide here. Yes, I do. Okay, so the value of this for us is $43.50 a discharge, and we do 3 calls for that amount of money for this hospital. So let's go to the next slide, what we do. So on day 1, 24 hours after they've been discharged from the hospital, we give the patient a call. We get information given to us by the hospital. The discharge folks decide whether or not this is going to be part of their discharge plan. If it is, they get us the information for the contact. We do a day 1 contact, a day 10 contact, and a day 30 contact. And what we'll ask them, or what we're assessing for largely, is their sense of safety and a lot of the things that we do with anybody else who would call our crisis lines who's having suicide ideation. And based on that, the assessment of how safe they are, we have an agreement with the hospital to either find them additional resources or, if appropriate, to refer them back to the hospital. So we can go to the next slide on that. Some of the challenges that we faced in doing this, we only receive close to 5 discharges per month from the hospital right now. The hospital has determined that they'll have their staff decide who's appropriate and who's not for this. And what our efforts are right now around that is having the nurses, the discharge staff who are feeling like the program's a success to talk and give stories to other staff to try and increase that. Another challenge that we faced is that many times we're not able to reach the individual who this has been written into their discharge plan. So we'll make many calls, many attempts at reaching them, and still sometimes we're not able to. Payment details. So what's primarily been looked at least I feel like in the ROI studies, is how do we get Medicaid or insurance companies to pay for it, which is a great way to go. For this initiative, what we've done is we're paid directly by the hospital. So the hospital has an incentive to look at their discharges and their readmissions, and they don't want readmits too quickly, and there's, you know, they get penalized, or at least they're beginning to get penalized, readmissions that happen too quickly after discharge. So there's a real incentive for them to make sure that if a person can be managed in an appropriate way outside of the hospital without a readmission, that they do that. For Oregon, another payer or party that's interested in this type of service are coordinated care organizations. And those organizations manage our pool of Medicaid dollars here. Work with the providers and the payers to figure out how to reduce costs. So we're having ongoing conversations with the largest CCO, coordinated care organization, in our greater Portland metropolitan area around this. Let's go to the next slide. And the ROI opportunities, so I was just talking about the coordinated care organizations. We thought that the place they would want to look at this with us was around individuals in crisis. And it actually turned out that what they're interested in first is setting up a addictions treatment clearinghouse. And their idea is that they will have their members, people who receive benefits, as well as their providers, like primary care physicians, have one line where they can call into to find out where treatment is. But when we started talking to them about the return on investment in helping people stay in recovery afterwards, it really became clear to them that an important component of this, if they move forward with the Addictions Clearinghouse, Treatment Clearinghouse, is going to be that follow-up component. So we're pretty excited about that one. I mentioned county crisis lines. We haven't needed to show them an ROI in that it's a need that they already have. We do have to show them what the benefit or the return on investment of using our crisis center versus hiring their own staff might be. Hospitals, we've done some work there and we're pursuing more, and then also psychiatric hospitals. And finally, of course, coordinated care organizations, which I've mentioned a number of times. But those are all folks who are looking for a return on investment in crisis line services. So that concludes my slides.
Thank you so much, David, for that review. A lot of good information there that you're sharing. For centers that might have some specific follow-up questions for David that they'd like to get to separately, you have his email address here as well at Lines for Life. So again, thank you to each of our speakers today that made themselves available in not just presenting, but of course preparing. There's always a lot that I want to check in on what questions people may have, and at the same time I'm going to see about getting a second poll question for all of you to take a minute to answer. That would be great. Very good. Now, I saw one question that came up in the chat, and then feel free, folks, to also voice a comment or question in addition to typing. Liz Sandwick had asked, is Network Center successfully being reimbursed by Medicaid or private insurance for an ED follow-up program? So I know Amy Bayless had responded no, but doing some nice things for free. But if anyone has anything along those lines that they'd like to share with Lisanne or this group, just give us an alert, or feel free to contact us after this, and we can get that information to Lisanne, or you can, of course, reach out to her directly if you're able to. But I understand that that's something people are going to wonder. There was also something, I don't know if I saw any other questions that I didn't get to address. So let me just get to what one of our participants had just chatted in to me separately, just to see if I had any thoughts about what, of course, has been going on with bringing attention to ALS, about the viral bucket challenge, and seeing if we think that perhaps that is an avenue to be a source of sustainability in our type of work. Is it harmful to fundraising efforts, or could it be helpful? I'm sure there are mixed thoughts about that, since we are hearing a lot of different reactions about the Ice Bucket Challenge. It certainly raises awareness, gets people curious what's going on there, and people then are in a feeling that they're participating in something together and end up usually donating some money, whether they pour the bucket of ice water on them or not. But there's been different reactions to that as the best mechanism, as well as the fact that there are many, many other causes for us to all be concerned about. And of course, in our case, we are always looking to bring attention to mental health issues and ways that people can get the help and support that they deserve. So that I just wanted to raise that in case people wanted to share.
Centers directly getting reimbursed through Medicaid services.
Yeah.
We don't have a lot of evidence for this yet, and it's one thing here that we've been really focusing on from a actually CPT code reimbursement side of things. At least it's a start for centers that are set up to have Medicaid reimbursement. But I do encourage each of you, as you're having conversations with hospitals and emergency departments, to see if they are billing for transitional-based services that are specific to crisis. So whether an individual is experiencing suicidal behavior or had been admitted under that, to ask them, and they may or may not share with you, but to ask them if they're knowledgeable about the transitional-based codes that are available in certain states. Now, I do believe there's about 11 total codes that could be utilized, but not all states have enacted all 11 of them. Some have enacted none of them. Some have enacted just a few of them. So in those conversations, it helps to educate them on what they could be doing when they get reimbursed for utilizing your services. Start having that conversation around, well, also the services that you're referring to are also not free, and look at partnerships potentially that way. And again, it's just something that is maybe there's a way to start building those relationships where services can be reimbursed outside of that typical reimbursement system. So I just wanted to put that out there.
No, that's great. Thank you, James. What other questions or comments might people want to share? We're hoping that this was, of course, valuable to each of you in some way. So far, it looks like most people can't wait to apply some of what you've learned today or what we've shared, so that's good news. Let's see. Oh, I see. If I'm going to just kind of share, some of you, of course, are reading this already, but there's, in terms of the challenges, we were just discussing in the ice bucket type challenge. On the positive side, yes, raises awareness. On the risk side, we have no control over the messages that might be sent when such a challenge goes viral. And with mental illness, suicide awareness, that could get difficult or tricky, so that's understood. These are all things to carefully think about. And then Courtney from San Francisco. Hi there, Courtney. You're interested in hearing what's recommended for sensitivity fundraising in the wake of a crisis, such as, of course, the recent death of Robin Williams. There's a lot of things surrounding that I think that many of us are thinking about right now with postvention and being prepared for these types of things that are so sensitivity fundraising is a good way of putting it. So if anyone wants to offer something along those lines, that would be great. Courtney is expressing concern about fundraising, seeming like it could be in bad taste. So these are definitely, I think, getting advisement on, like we were saying earlier, marketing and how things are branded and shared and communicated is quite important.
Hey, Karen.
Yeah, Carol, go ahead.
This is Carol. I just wanted to share something. I actually received a link to an article that kind of analyzed why the Ice Bucket Challenge was so effective. And it, not all, but it actually brought up some really interesting points to consider. So I'm just going to include that in the chat section, a link to that article. So you guys might want to check it out. It's got some interesting just notes in terms of why it went viral and why it was so engaging for so many people. So maybe that will help generate some ideas if you guys want to do something locally at your center.
That's a good idea. Thank you, Carol, for sharing that. I know there's been a lot of different articles popping up showing both sides of this. And yes, the toolkit again is specific for the Lifeline Network Crisis Centers. I know we have, I believe, some NASCOD members that we like to invite to all of our webinars as we roll out the Lifeline best practices. So there, of course, anything today that you think is going to give you some helpful hints, take away with you. What's on the Network Resource Center, for the most part, is accessible through that route for our current Lifeline crisis centers. What other questions or comments might there be as we wrap up? I want to also give our speakers a final chance if there's anything you'd like to add today or just say as we close. Mary?
Just nothing more from me except to thank everyone for giving me this opportunity to talk a little bit about the kit.
Perfect. Well, thank you again. What about Mike? Are you still there?
Yeah, I just want to thank you, Karen, for the opportunity to get to talk about the exciting things that we were able to do with the materials, and thank Mary and her colleagues for developing this. I think this is going to be a real boon to a lot of crisis centers.
Thank you so much, Mike. I agree. And James, anything you'd like to add?
Karen, you did a great job pulling it together, and thank all the speakers. And one of the things that I was reflecting on when going through this, actually I was typing with Jennifer Battle on the side, is that we highlight a lot of times the struggles that centers go through, but not necessarily all the successes, which can really illuminate ways that you've been able to get sustainability at a local community level. And maybe there's a way to do that more in the future to show how centers are progressively moving forward. And again, I see a lot of people talk about their services being free, and I always encourage people not to use that, to say that these services are definitely not free. They cost someone, and a lot of times without showing the true impact of those costs, the funding dwindles, and I'm sure many of you have seen that. So again, just thank everyone else that's been on, and all the presenters, and Karen, specifically you. Good job.
All right. Well, thank you, James. But definitely, we want to really remember all of the successful and positive things that we're all contributing to as a network, not just within Lifeline, but beyond in our common goal. And so there's a lot of good stuff happening. David, anything you'd like to add as we wrap up and let you go back on vacation?
No, just thank you, Karen, and thank you to NSPL for putting these webinars on. I think it's a very valuable service.
Thank you. Okay, well, we are going to wrap up for now. John from Idaho, if we can get back to you if we find out about any particular centers that might be getting reimbursed in some of the ways that James perhaps was pointing to, so we can follow up with you. Thank you so much, everyone, for taking the time to also answer those poll questions, and we hope that you have a great afternoon. Stay tuned. Evaluation webinar, so look out for that. Thank you all.